Excited to see people introducing themselves in the chat. Please continue to do that. So we'll get started in 2 minutes. All right, I'd like to welcome everybody to our BHIP resilience breaks. I wish I could remember what number we're on. I think this might be our lucky 13th, but I'm not 100% positive about that. My name is Amy Betancourt, and I am the Director of Research and Evaluation for Maryland BHIP, and it is my pleasure to introduce our speaker today, Dr. Hal Kronsberg. Dr. Kronsberg is a former 7th grade public school teacher. He's interested in clinical, educational, his clinical, educational, and research interests focus on providing mental health care outside of the traditional clinic setting. He serves as a psychiatrist for Johns Hopkins Bayview's Medical Center's school-based mental health program in numerous Baltimore City public schools, as well as for the Child Mobile Treatment Team, which sees children directly in their homes and communities. In addition to clinical care and research, Dr. Kronsberg is also highly involved in clinical education, and he's the Associate Program Director for the Johns Hopkins Child and Adolescent Psychiatry Fellowship. And he also works with us on BHIP, involved in our Pediatric Primary Cares Project ECHO, which aims to educate pediatricians across Maryland on topics and practices related to supporting child and adolescent mental health. And I'm really excited to turn it over to Dr. Kronsberg today to talk about self-injury.
Thank you so much, Amy. I appreciate it. I'm just going to share my screen. And one thing that I actually forgot about was probably the most relevant thing that I do as relates to this topic was I spent a few years before medical school working at 3 East, which is a residential dialectical behavior therapy program at McLean Hospital that worked almost exclusively with adolescents, particularly at the time, adolescent girls who had really significant self-injury problems. And it's a really wonderful introduction to dialectical behavior therapy, and it was just a really great experience. And that's kind of how I come to this from. So I'm just going to go ahead and get started. So today I'm going to be talking about adolescent self-injury, in particular, kind of how to understand it and kind of manage it in a clinical setting. As far as conflicts of interest go, I don't have any conflicts to disclose. I'm on the faculty at Johns Hopkins, and the Project ECHO, which I'm a part of, gets its funding through HRSA. A couple of quick definitions. When I talk about self-harm or self-injury, which is sometimes known as NSSI, or non-suicidal self-injury, what that means is deliberate inducement of pain or tissue damage without suicidal intent. And it often refers to cutting or scratching. And again, that without suicidal intent is a really important piece when we talk about it. A couple of learning objectives. I want to, by the end, to identify conditions and characteristics associated with self-injury, identify 4 risk factors for when self-injury is most associated with suicide attempts, know how to ask about self-injury and understand its function and assess its dangerousness, and identify the 2 most common treatments to help kids who engage in self-harm. So the other thing that I do want to point out, and I think this is helpful for how we think about self-harm, is to consider it as a behavior. And the reason for that is, unlike a diagnosis, which is sort of the endpoint of an investigation, when we think about a behavior, that's often where our investigation has to begin. Because self-harm is not necessarily kind of a treatable disorder in and of itself, but it can signal a lot of other things going on. There's something about self-harm when kids engage that reinforces it, that enables those behaviors to persist. And therefore, to stop self-harm, you need to address the antecedents and consequences as well. So again, when we learn about that a kid is engaging in self-harm, that means it's time to really dig in and get to the bottom of what's going on, as opposed to just stop and saying, okay, this is the thing we have to put an end to. So I do want to talk, for starters, just about prevalence, risk factors, and characteristics. And a lot of the data that I'm going to discuss comes from this really, really great, gigantic meta-analysis that looked at all sorts of different studies of self-injury over a 25-year period. It looked at 261 studies and included 31,000 children that had engaged in self-harm. And before we do that, I'm going to see if I can figure out how to get this to work. So I make no promises. I'd like to ask everybody a question. If you had to guess, would you say that most kids who engage in self-harm would go on to do so either 1 or 2 times, 3 to 10 times, or more than 10 times? And I see answers starting to come in. Give it a couple more seconds. So I'll be honest, I don't totally know how to share the poll, but I'm just going to slide this over to the screen that you all can view. So hopefully everybody can see the results. So so about 75% of you all have finished, and it looks like sort of the overwhelming non-answer is 1 to 2 times, and then 3 to 10 times, and then more than 10 times. So with that in mind, let's take a look. So according to that huge meta-analysis study, what it actually found was that about 47% of kids would self-harm once or twice. And then somewhere around 40% of kids would engage in self-injury between 3 and 10 times. And a much smaller minority, only about 5% of kids who do engage in self-harm will go on to do so more than 10 times. And I suspect actually what's reflected in the answers that I saw from folks, and I was surprised by this too, is that the vast majority of kids who self-harm once or twice kind of never come to our attention. So we're disproportionately seeing the kids who engage in self-harm much more frequently. In general, the lifetime prevalence is about 23%. Females are 1.72 times more likely than males. Typically, self-harm engages, kids start engaging around 13 years. And one question that people always ask is, are rates increasing? And you can kind of see from the from this graph, which is every point represents kind of the community prevalence of the sample that's being drawn from. And if you can see my mouse, if you had to guess a trend line, there has been a steady increase in incidence of self-harm over the last 25 years or so. So the other thing to think about is, okay, so as I said, self-harm is a starting point for investigation. Are there different particular psychiatric illnesses that are associated with self-harm? And in general, we can see, and this is a study of kids who were hospitalized on an inpatient unit who engaged in self-harm. So in general, the kids that are represented by this study likely have greater severity of illness than the outpatient community samples. But you can see here, there are higher rates of depression in kids who engage in self-harm, high rates of trauma, high rates of problems with what you could call self-regulation. And there you see these externalizing disorders, oppositional defiant disorder, conduct disorder, and also high rates of substance use. And the idea here is not to use these numbers and rely on them too heavily, but to sort of recognize that self-harm can be associated with so many different conditions, which again speaks to the need for, okay, once we know that there's self-harm, there's a lot more figuring out what else is going on in order to figure out what to do next. But for many of us, particularly folks that are in primary care settings, but really for all of us, the thing that we need to be thinking about a lot is what's the association with self-harm and suicide. I've encountered a kid who's shared that they're engaging in self-harm. What does this actually mean about their safety as far as keeping themselves alive go? And there are a number of predictors that would make self-harm along with sort of this other variable, an indication that this kid is at a much higher risk for suicide, in particular, engaging in multiple modes or methods of self-injury. And I think that's kind of, in some ways that makes sense, because if kids are engaging in multiple different methods of self-injury, in some ways what that's telling you is it's not working that well. It's not helping them kind of get through the moment as they may describe that it is. If they have to keep trying different things in order to be able to tolerate their emotional experience at that time. Hopelessness is also associated with self-harm and suicide attempt, parental conflict, and I put it in bold because this was by far the biggest predictor, which is depressive symptoms. And as an example of how that works, so this is from a large study of British adolescents who had depression and were being treated with Prozac and therapy. Of all of the kids that are enrolled in the study, by about 28 weeks, 60% were either much or very much improved with treatment. And so they looked and they wanted to see, okay, what kids who engaged in self-harm that were enrolled in this study, what did that mean as far as their ability to stay safe in the future? So in general, among the kids who had not engaged in self-harm at the start of the study, about 1 in 5 would go on to self-harm by 6 months, and about 1 in 5 would go on to attempt suicide. For the kids who had engaged in self-harm by the start of enrolling in this study, those kids actually have a 3 times higher risk for self-harming again, and more than twice the risk of ultimately attempting suicide. So when self-injury and depression co-occur, we really need to emphasize safety planning around suicidal thoughts and urges, because we know these things are going to be more likely to suicidality is going to be more likely to occur in kids who do have a history of self-harm. So I do now want to transition a little bit to talking about what is it about the conditions that kids are in and their own sort of internal emotional experience that leads to self-harm or that's associated with self-harm. And this is kind of a cool study that looked at something called expressed emotion within a family. And actually, as it turns out, the familial environment is really important. Expressed emotion basically is the extent to which family members express criticism and hostility towards and are emotionally over-involved with a specific person. So in particular, it looked at parental criticism, adolescent self-criticism, and parental over-involvement. And this is just kind of a funny way to get at those things. So basically, the people that were enrolled in this study, you ask a parent, I'd like to hear your thoughts and feelings about your kid in your own words and without my interrupting with any questions or comments. When I ask you to begin, I'd like you to speak for 5 minutes and tell me what kind of person your child is and how the two of you get along together. It's kind of fascinating to think about how we might answer for our own children or how our own parents might answer about us. But so these statements were transcribed and then coded by a team of trained psychologists, and they took a total of 36 different adolescent parent dyads and then looked at what was different about the kids where there was self-harm, kids who were engaging in self-harm and the kids who weren't. And what they found was high EE, or expressed emotion, in general was associated with self-harm and suicidal ideation and behavior. However, when it comes to self-injurious behavior, it was only the high parental criticism and not over-involvement that was associated with self-injurious behavior. And among kids who engaged in a lot of self-criticism, that didn't seem to impact things one way or another when parents weren't highly critical of their kids. But this combination of high levels of parental criticism combined with high levels of adolescent self-criticism was very predictive of kids who engage in self-harm. And so, in some ways, those are two things which together can make kind of a toxic mixture in some ways. And the reason that I think this is so important is when we start to think about treatments, it becomes increasingly apparent it's really important to work with parents as well, because this is actually quite kind of a complicated dynamic process that's going on within the family too. So the other question is there something different about the way these kids experience their emotions? And one of the same researchers, Matt Nock, who's done a ton of research on kids who engage in self-harm and suicide, basically decided to try to find this out. So they took 92 different adolescents, 60 of whom engaged in self-harm. And other than that, there weren't a whole lot of differences between them. And they subjected them to these tests. So the overall measure of sort of emotional and physiological arousal was skin conduction testing, which basically you put these sort of electrodes on people's skin, and you can get a sense of it's a measure of a bunch of different forms of physiological arousal. And then they had these kids do two different tests. One was the distress tolerance test, which is this card sorting test that it seems like you can solve it, but you actually can't. And the other is social problem solving skills test, where you imagine different scenarios and you think of all the different ways that you can respond. So when you put these kids in the distress tolerance test, which is the sort of unsolvable puzzle test, what they found was really interesting, which is that kids who engaged in self-harm, they would get like really physiologically aroused. And as the task went on, they wouldn't habituate, they wouldn't settle down. And this was especially the case for certain kids who engage in self-harm. But overall, and you can see from the graph, it really shoots up and they just stay getting more and more and more physiologically aroused the more they struggled through this. Meanwhile, when you look at kids who don't engage in self-harm, they got a little bit sort of physiologically revved up, but then they would start to settle, usually after a couple of minutes, and actually kind of return back to their baseline. So the idea here is these kids feel their feelings in really, really intense ways, and it's hard for them to settle down. The other thing that was interesting is that the kids who engage in self-harm, they also quit the task earlier than the kids who don't. So it's thought that there may be some particular challenges with sort of frustration tolerance and distress tolerance. And then finally, in the social problem solving test, both groups were able to generate, so the goal is to generate as many different solutions to these interpersonal problems as possible, and both groups generated the same number of solutions. The kids who engaged in self-harm tended to be a lot more harsh about their solutions. And when they opted to choose what they thought was sort of the optimal solution to this social problem, they tended to choose kind of less effective solutions. And so it was thought that, there wasn't, it's not an issue of intelligence with these kids, but there are times, particularly in social settings, where they may struggle with judgment in interpersonal situations. So a couple of take-home points about this. Cutting alone doesn't tell us everything about diagnosis by any means. In general, kids who engage in self-harm, they frequently do so about 1 to 2 times per week. And these are the kids who frequently engage in self-harm. Kids who self-harm tend to struggle with strong emotions and can be harshly judgmental. Depressive symptoms, hopelessness, and high stress can predict self-harm. Social support is one of the things that can protect, and in particular, watch out for different types of self-harm and depressive symptoms that sort of co-occur with self-harm. And then finally, families are really important here. So the next question that is important for us to dig into is, why does this happen? And that's one of the first things that parents will often ask. Why is my kid doing this? They find it so distressing that their kid may engage in self-harm. Matt Nock, who's the same researcher that I've talked about, basically says, one way for us to think about it is there are 4 different reasons why a kid might engage in self-harm. The first is to increase a desired feeling. So one way that might be is self-punishment, self-stimulation. We call it, quote unquote, the endorphin release. And there is shown to be kind of a release of endogenous opioids when kids do engage in self-harm. It could also be to decrease an undesired feeling. So for kids that are feeling overwhelmed, they'll say when they engage in self-harm, it actually reduces the intensity of that feeling, either sadness, anger, and they'll often cite this feeling of emptiness or numbness that's really intolerable, and that when they engage in self-harm, that'll reduce that. Another possibility is to increase a desired social response. That may be to gain attention or support. And I put this in quotes because this word makes my skin crawl when people use it, which is manipulation. Another way to think about it is this is a kid who's trying to get their needs met. And then finally, to decrease an undesired social response, such as stopping bullying or parents fighting. So I'm going to try another poll just to see kind of what we're thinking. there was a study of kids that actually used beepers from about 10 years ago, where kids who engage in self-harm would periodically get paged, and they'd have to write down how they're feeling. And when they were able to page kids who had either just engaged in self-harm or about to engage in self-harm, they had to sort of walk through what they were thinking at that time. And so the question that I just wanted to see what people are thinking, if we had to guess of those 4 different factors, what do we think is the most common reason that people engage in self-harm? So I'm going to open this poll up. And so hopefully you guys are seeing it. And it looks like the answers are starting to slowly come in. Awesome. So I'm going to slide this over. Hopefully you all can see this on my screen when I put this up there. But I would say the overwhelming answer that people are describing is B. Much less, but still in second place is A. And so what that sort of, it seems like what the general consensus is that self-injury is more about kind of regulating an internal state than it is about kind of communicating to the outside. And actually, when we see, according to the study, actually, that's exactly right. And pretty much in keeping with what the vast majority of folks said, 65% of the time, kids who engage in self-harm are engaging to decrease that unpleasant feeling. They particularly cited feeling overwhelmed and escaping anxiety, but also sadness, anger, or to escape from a bad thought or a bad memory. At the very, very bottom, only 4% or 15% of the time did kids state that they would engage in self-harm because of some interpersonal outcome that they were trying to either experience or not experience. So now that we know a little bit about kids who do engage in self-harm, I think it's important to think about, okay, well, now what? Once we find out that a kid is engaging in self-harm, what should we be asking? What should we be doing? And a couple of things about this. So I'm gonna basically share all of the things that I think you can do or you ought to do if you have all the time in the world. But I recognize many of the folks here are primary care providers, and we don't have all the time in the world. So I put in bold the things that we want to prioritize in, let's say we only have a 15-minute visit, or all of a sudden it comes out in a different visit and we have to suddenly pivot to it. So here are all the things that we can do, but also I think how we might want to prioritize it if our time is limited. So a couple of guiding principles when we dive in. So the first is to respond with supportive concern. And this may seem kind of obvious to folks, but I do think it's important to kind of spell out more specifically. We don't want to overreact to this. And it's important to remind ourselves, in almost all cases, engaging in self-harm is not the same as a suicide attempt. And oftentimes that's something that we have to educate parents about too. And at the same time, it is a dangerous thing to engage in, and it does confer a higher risk for suicide. So we want to be in this level, sort of in this middle ground between not overreacting, but also not underreacting. It's important to review our confidentiality rules, but I always tell people, give yourself a little bit of wiggle room. So typically when I talk about confidentiality with kids, I'll be very clear about, give them an example of something that's, if they share with me, that will absolutely stay between us. And then an example of something that when they share with me, I'm going to have to talk to their parents about. And then I make sure to mention that there is going to be some like gray areas in between. And no matter what happens, so we're going to talk this through. I'm not going to surprise you with what I tell your parents when they walk in the room or when I get a chance to speak with them. But that we're going to talk about it first. It's important to keep those 4 outcome model in mind, because that's going to help guide us towards what to do next. And then finally, we always want to think about safety first. Just because a kid may engage in self-harm and they may say this was absolutely not a suicide attempt, doesn't mean that they aren't also suicidal at that time. So we always want to be thinking about safety when it happens. So when I ask kids about, we can split it into kind of what, why, and what's next. So when asking about the sort of what questions, I always like to know, when did it start? How chronic a problem has this been? And then asking more detailed questions about how you engage in self-harm. engage by cutting, burning, scratching, so on and so forth. There are all of these different ways. And that's important because we're oftentimes going to want a safety plan with parents, and knowing the method is going to be really important because we'll often want to try to make it more challenging for kids to engage in self-harm. So if they're using a, if they're burning, we want to remove lighters. If they're engaging by cutting, we want to maybe remove sharps from the house. I also think it's important to ask how often kids engage in self-harm. And also I like to ask where and with what. And typically I'll ask to see scars. And the reason for that is that there are many kids who have shared with me that they engage in self-harm on an almost everyday basis. And then, I'll ask to where they engage in self-harm. And there may not be, a single mark on their arm, which suggests that this is very, very shallow. And there are other kids who say they hardly ever self-harm, but the scars can be really, really significant. So I think it's important to both, take what our kids are telling us, but also to look at how their body is experiencing that as well. And then I also like to ask, who knows about this and how do those people feel about it? And in particular, what do your parents know about your self-harm? I do think, as I mentioned before, the why is really important because we're also going to think about, we need to know why in order to actually help solve the problem. So in general, how do you feel before you cut? But I also ask, what does it do for you? Because we recognize that kids don't engage in self-harm, because they're crazy. They do it because it's something that they actually feel like in many cases they need to get through a really challenging moment. And so I'll ask, does it help you feel more or less of a particular emotion? It's also, I think, important to ask about how other people react and how you feel about that reaction, and also how well does it work. There are many kids who engage quite frequently, and they'll say, yeah, it gets me through the moment, but if they need to engage really frequently, maybe it's not working that well. And the reason that I think that approach can be useful is it's something of a motivational interviewing style. We want to try to plant the seed for reduction of use and ultimately abstinence of self-harm. Sometimes I'll ask kids, how long do you envision yourself engaging in this behavior for? Because they do envision a future in which it's not something that they need to rely on, and trying to help them sort of visualize what that would be like and why they might have that goal, and to be able to articulate that, I think, can be really important for shoring up motivation. So what next? Also really critical now that we know this. So the first thing I think we always have to do is assess suicidality. And as I said before, self-harm may not be a suicide attempt, but the person engaging in self-harm may still be suicidal. I also do think it's important to figure out what else we may need to treat. So remember, there are all of these comorbid disorders that are associated with it. And it's also, unfortunate, but true, no medication can treat self-harm. There have been tons of different things that have been studied over the years, and nothing really works out. But there are many medications that can be helpful in treating those comorbid disorders. It may be the case that you might want a quick turnaround visit with a patient that you see that's engaging in self-harm, so that you can dive more deeply into those comorbidities, whether that's doing a SCARED or a PHQ-9 or a more in-depth substance use screening to figure out, okay, what does this kid need, and then what's the most appropriate treatment we can try to refer them to. I always feel like it's really important that we don't find ourselves in the role of secret keeper. And typically when I'm meeting a kid who reveals that they're engaging in self-harm, one of the questions that I'll ask them is, how are we going to talk to your parents about cutting? This is not a secret that I feel like I can reasonably just keep from your folks, especially if they didn't know that it's ever happened before. And I do think in these cases, therapy is going to be necessary. And I'll talk a little bit more about what the treatments that we know are helpful are. So once we complete an evaluation of suicidality, the next step is really to think about a safety plan and to construct a safety plan, often with parents. So this is a template that you may be able to see on the right-hand side of your screen. So this is actually from Suicide Prevention Hotline. There have been a number of studies that seem to indicate that safety planning is pretty helpful in reducing suicide attempts and also in keeping kids safe. So I think it's really important. There's no such thing as contracting for safety, which is when a kid says, I'm not going to do something. We don't want to just rely on words, because that puts those kids in an unfair position. So we want to start taking steps, and that includes removing lethal means from the home, such as firearms, pills, etc. We want to empower parents to gently ask their kids about suicide. A thing that parents often worry about is, if I ask my kid if they're thinking of ending their life, I'm going to implant this idea in their head, and that's actually not the case. And in some cases, they may need a little bit of help to gently be able to ask some of these questions about safety without asking their teenager and pounding on their door every 5 minutes, because they're going to be guided by their own anxiety. It might be necessary to monitor social media. And when we're constructing a safety plan, we want to include a lot of if-then statements. So that may be, if you are feeling like you're having urges to self-harm, then this would be the next step. Or if you're having thoughts about wanting to end your life, then this would be the next step. And it's helpful to post this safety plan in a really public place. Make many copies of it if necessary. Some kids have the safety plan actually kind of on them, on their person. So as I mentioned before, therapy is going to be necessary and important. And the reason for that is because we know pretty well that treatments actually can be helpful. So there are a number of different therapies that have been shown to be effective in treating kids who engage in self-harm. In particular, dialectical behavior therapy, which is something that I had mentioned before that I had practiced, cognitive behavioral therapy, and mentalization-based therapy. But most importantly, when we delve into what's the secret sauce in all of these treatments, we see that focus on family interactions is really important. And if it can be clear when we think back to the expressed emotion data that showed high parental criticism can be a risk factor for self-harm, good treatments are going to be really helpful for teaching families to communicate in a more effective and validating way. Frequent meetings with the adolescent is also really useful. The more kids are seen in treatment, the less they seem to engage in self-harm. And there's also an emphasis in self-care, maintaining sobriety, sleeping better, increasing positive experience as well. I do want to talk a little bit about both DBT and CBT, and I put them side by side. I'm leaving out mentalization-based therapy because even though it is an effective treatment, honestly, it's really hard to find. And I think we're going to be much more likely to find in our community people who practice cognitive behavioral therapy, and to a lesser extent, DBT or dialectical behavioral therapy. So DBT has the strongest evidence base. It's a mix of group and individual treatment. So there are these things called skills groups, which are almost like classes where you'll learn different coping skills to manage through difficulty, and then individual treatment that's really all about how our kids are putting those skills to use. There is a parent component. Parents also have their own set of skills that they need to learn. And again, the idea is that kids who engage in self-harm kind of have a skills deficit. And ultimately, if they are able to pay close enough attention to what they're experiencing, and if they're motivated, they can replace self-injury with a different coping skill that serves the same kind of functional purpose. And that's why understanding the function of the self-harm can be really useful. Finally, kids who are in DBT, if this is like a strict DBT program, they do have access 24 hours a day in most cases to an on-call skills coach. So if a kid is feeling really overwhelmed and that they're not able to keep themselves from engaging in self-harm, they will have access. They can call a number and they'll get a chance to speak to a skills coach, something that I got a chance to do when I was working at 3 East as well. And just the presence of a skills coach can often take down the temperature in conflicts, and a kid who knows that there's a person out there who can help them when they need it can help them tolerate some of those emotions a little bit better in some cases. The thing about DBT though is it's hard to find, in particular, really rigorous program that follows the DBT protocol. So fortunately, even though the evidence base is a little bit weaker, cognitive behavior therapy has been shown to be helpful. Good CBT tends to have individual and parent components as well. There's an emphasis on thoughts and behaviors, and the thoughts and behaviors that can lead to self-harm. In some ways, a lot of the DBT is actually an adaptation of cognitive behavioral therapy, in particular for folks that engage in self-harm. CBT tends not to have that on-call skills coaching, but it's really much more commonly found in many more places. And in particular, CBT is, we call this sort of our broad spectrum antibiotic of therapy. It's used to treat lots of different comorbid conditions, from depressive disorders to anxiety disorders to all sorts of different things. So I do want to give an example of DBT and kind of how it works. So here, here's an example of a distress tolerance skill. There are a couple of different modules in DBT, and those are all skills that are meant to kind of complement one another, but also serve different purposes. So one set of skills is called distress tolerance, and these are for kids who are in crisis. And basically, you could describe distress tolerance skills these are skills that you use to not make a bad situation worse. So another example of the skills modules would be interpersonal effectiveness, which is exactly what it sounds like, because remember, these are kids sometimes that can really struggle in interpersonal situations. So the skills training tends to be focused on, how to better navigate the incredibly challenging interpersonal world of adolescence. So this is an example of a distress tolerance skill. It's called the TIP skill. And this is one that I would say I find that kids tend to use as almost their most go-to skill in kind of reducing the level of emotion dysregulation they may be experiencing internally. So there are 4 different ways that you can do it with the TIP skill. The T stands for temperature. So you can change your body temperature, and that can be with, for instance, a cold shower or a hot shower. And the idea is to try to evoke like a parasympathetic surge. And one of the most popular things kids would do is called ice diving, where you fill a bowl of ice water and then douse your head in it. And what that will do is it will very dramatically and very quickly kind of lower that level of physiologic arousal. Another example is intense exercises, going up and down stairs, going for a run. Paced breathing, or sometimes called box breathing, is one of the P's. And then finally, paired muscle relaxation or progressive muscle relaxation sometimes. So these are sort of a set of 4 kind of go-to skills that kids can go to when they're particularly vulnerable to engage in self-harm, and sort of an example of how DBT works. And then, the next week you would show up and then you would learn something different, the distraction skills, for instance. So it's really, really hard to work with kids who engage in self-harm without also engaging parents. And I do think psychoeducation is one of the most important things that we can do, and try to demystify what's going on, because it's understandable that when parents find out that their kids engaging in self-harm, it's really scary for them. I am going to recommend this one book that I think is really good. It's called Helping Teens Who Cut. It's intended for lay audience, but it's written by Michael Hollander, who's a major trainer for child and adolescent DBT. And this explains the concepts and skills of DBT, but also it helps parents kind of respond a little bit more effectively to emotional distress. Talks a lot about validation as a skill, and validation in particular, I think, is probably the most important thing that parents can start to do, to shift from always trying to solve what they perceive as the problem to instead try more to understand the nature of the kid's distress, and to be able to kind of recognize that how they're feeling makes sense, and that they have a right to feel that way. Additionally, there are a number of different websites that are out there. So there was a study that was published a few years ago in JAMA that looked at if parents Google self-injury, what do they find out? And they had a series of sort of self-injury myths, many of which we've spoken about already today. And they found that for the most part, if you just Google self-injury, you will just stumble on myth after myth after myth after myth. And so in that paper, they ended up recommending 3 particular websites that they thought had reliable and good data on it. There's the Self-Injury Outreach and Support Organization, Self-Abuse Finally Ends, and then Cornell has a research program on self-injurious behavior. So you can see that website address has been updated. So I put the website there. So a couple of key points that I just wanted to review before we finish up. So the first is, the what's of cutting. So cutting alone doesn't tell us everything about the diagnosis. Kids who cut rarely engage in more than 10 discrete episodes in their lives, but often those kids who engage more often are the ones that we that come to see us. Kids who do self-harm struggle more with strong emotions, and they can sometimes have poor social judgment. And, even though non-suicidal self-injury is not necessarily a suicide attempt, it is strongly associated with future suicide attempts. We know that most kids typically engage in self-harm to make a feeling go away, and that it's rarely for attention, which I think is a really important point for parents who sometimes can see it that way. And then, the what nows, we want to assess suicidality, we want to determine the function of self-harm, and we want to identify comorbidity so we can make sure that kids are in the appropriate treatment. And then what next? Treatment works, which is great news for us. This is something that we can help kids with. So I do have a number of references, which you can feel free to take a look at. And then lastly, I did just want to end with the Maryland BHIP information. So so if you have questions, you can reach out, or need help, you can reach out to us this way. And I think that wraps us up. So I'm going to stop sharing my screen and turn things back over to Amy.
Thank you, Hal. That was wonderful. So I put this in the chat, but please feel free to ask questions in the chat or in the Q&A, and we will read them out loud, and Dr. Kronzberg will share his insights with us. While we are waiting for questions to come in, I will ask one. So you talked a lot about how we once we kind of have some sense that cutting is going on or self-injury is happening, how to kind of have a more in-depth conversation with the adolescent. What would you recommend when you suspect it, but they have not shared anything yet and there aren't sort of initial visible signs? How might you open that conversation? Any differences?
So that's a really good question. I guess the question is, what I'd be curious is, like, why do I suspect it? And not to be too, shrinky here, but if there is something that I suspected, I'm kind of curious about it, and I'm wondering what's going on, I'll usually just ask about that rather than leap to the conclusion of this kid is engaging in self-harm. For instance, if I know this kid is struggling immensely with intense emotions, for instance, or has all of these risk factors, I might ask, well, how do you deal with it? I would guess it's really hard when you feel your feelings as intensely as you do. And, and sometimes you experience your parents as being like really critical. Like, how do you deal with it? And then sometimes I might even go a step further and say, a lot of kids deal with these really intense emotions by engaging in a behavior that might solve the problem in the short term, but isn't necessarily helpful in the long term, such as, and listing a bunch of things. So such as, a lot of kids do engage in self-harm by cutting. They may engage in substance use. They may smoke weed to kind of settle themselves down. So kind of not so much normalizing it, but sort of recognizing that, yeah, this is actually kind of a way a lot of kids deal with those feelings. So I don't know if that sort of answers that question.
Yeah. I mean, I think you're pointing out that when you suspect, you try to probe a little bit on whatever the things that are sort of leading to that suspicion. So we have a few questions in the chat from Dr. Tellerman. To what degree do you think self-harm is influenced by social media, including peers and websites?
Oh, so that's a really interesting question. And this is a little bit more conjecture, but I would say, we do know that it does seem that self-injury is on the rise. And I think social media has risen kind of concurrently with self-injury. Granted, there are lots that's more correlative, but I will say there are many kids that I've worked with that specifically will point to a handful of different websites that they go to that have been sort of what they say like pro self-injury, in the same way that there are many different like pro eating disorder websites. So so some kids may actually feel very validated. They're engaging in self-harm, and they find this online community that also engages in self-harm, and so they may feel a little bit less motivated to reduce their use or to stop using, or feel like this is actually a totally okay thing to do. So again, it's a little bit conjecture, but I definitely do think that is part of it.
And another question from Amanda: what are your thoughts around self-harm group therapy groups? And I think this may tie in a little bit to what you were just talking about.
Yeah, so I think it really depends on what's going on in the group. So as an example, like dialectical behavior therapy, it has a huge group component, and I think it's that group experience where kids, in particular, are talking about coping skills and their success or their pitfalls. And this is actually one thing I love about DBT is many of the skills and the acronyms for the skills are absolutely ridiculous. And there is something powerful about engaging in a skill where you're like, this is really stupid, this will never work. And then all of a sudden you're like, oh my God, it actually did work. And being in this sort of supportive peer community. So I think when the peer group is kind of supportive and shares sort of similar goals of reducing self-harm, I think it can be really, really positive. And that's why one of the things I really like about DBT is that sort of kind of peer community that you're able to build of kids who have similar experiences, so they can feel validated, but they're also motivated to reduce their self-harm.
So it's when that group process really works, right? Because there's this shared idea, we recognize this is something that's happening and we want to do something to change it. Emily writes, the psychiatrist at my work asks parents to check their child for cutting marks once per week with the child wearing bra and underwear. This differs from recommendations I have read. What are your thoughts?
Ooh, so, you know, I think parents and parents, kids, and their treatment team, I think it's really important that they work together as a team, that they can sort of recognize that self-injury is something that is not a helpful way to deal with emotional distress in the long term. Without knowing any of the specifics about this case, like it's hard to say with a great deal of specificity, like, you know, what makes sense and what doesn't make sense. But I really think it's important to, whenever possible, enlist the kids that we work with. And okay, you know, we want how can we help you stay safe? And I can envision some kids say, you know what, I need this level of scrutiny. And I can see a lot of other kids saying, oh my God, this is so unbelievably invasive. Right away, this puts us at odds and leads to us being kind of in conflict with one another. So, you know, I think actually there are some kids who in some cases are kind of like desperate for a little bit more, to feel a little bit more kind of contained and under control. And so some kids will openly say, I need you to scrutinize everything I do. But again, I would be reluctant to do that as sort of the default. I think that's got to be a conclusion that is reached with the entire team, including parent, doc, or therapist, and kid.
Yeah, I think that's a really good point about knowing and talking to the kid about what they want and what they need, and kind of working together to make that happen. Taylor asks, can we recommend the TIPS intervention to our patients that we see in primary care with self-harm?
So I think you can. I think the DBT skills are all useful skills to recommend. There's so many different sort of DBT websites that exist. Sometimes I worry that we can just sort of throw a couple of DBT skills at people and sort of just hope that's going to be good enough. And the reality is these skills are hard to use, and it's hard to feel motivated to use these skills when you need to use them. So I do think in an ideal world, we're using these skills within the context of being in treatment that's going to help us kind of explore, you know, how did it work? Or if it didn't happen, you know, what got in the way of making use of the skills? So I think it's really important for people to be aware of the skills, but I also think it's important for us to recognize that just, you know, knowing what a skill is doesn't mean it's going to be utilized when kids need to use it. But absolutely, I think it's really important for parents, especially that may be interested in getting their kids engaged in DBT, to familiarize themselves with that treatment, because the more parents and families know what the skills are, the more they can help kids make use of it in a time of crisis.
That totally makes sense. How would you recommend to approach a situation when you find signs of cutting on a physical exam, but the adolescent denies it?
Oh, that's a really good question. And it's tricky too, because a lot of it's going to depend on your relationship with the kid. And I would say, you know, when I sort of joke that in some ways, you know, all of child psychiatry is distilled to asking questions, hearing stories, and then thinking about them, and when they don't make sense, being like, wait a second, I don't know that that makes any sense. Help me understand this. So, to the extent that it's possible, obviously we don't want to just like, shout it at the kids that we're seeing, like, why are you lying to me? But I think, I've had kids who have scars and they're like, oh, it's because the cat did it. And you're just like, I can appreciate what you're saying. And I wonder if there's maybe a better explanation. Or I'm a little worried about that. I'm wondering if you could help me understand a little bit better what exactly happened. And so, again, I think there are times where being a little bit gently confrontational makes sense. But I also think, it's important to bring up with parents that, I noticed that there were these scars. The kid is saying that there was a situation with the cat. I don't totally know what to make of it, but I think it's something that, we should keep an eye on just to make sure that we don't have more incidents with the cat.
So pushing it a little, if you can, but then also following up with the parent about it.
Yeah, absolutely. Because we can't read minds. It's not right. And it's not our job either. We do the best that we can.
Right. So Joyce asks, you mentioned that medication is not effective for NSSI. Some are using naltrexone to help with the impulsivity. What are your thoughts?
So naltrexone's been people have been using this on and off for decades, and I can appreciate that when a problem is not responding to treatment, that we'll use stuff where maybe the evidence isn't so great. There have been a number of studies on naltrexone, and it hasn't shown that it hasn't shown that it's terribly effective in the treatment of non-suicidal self-harm. But I sort of can appreciate the position that people can be in sometimes say, I'm not really sure what else to do. But I think it's important for us to kind of recognize the limitations of medications and what it can do and what it can't do, and to not oversell it when we do that. So, naltrexone is something that I do see people use from time to time. Just the reality is the evidence base isn't there.
Thank you. That's helpful. Audrey writes, how would you process repeated self-injurious thoughts and statements by a 7-year-old or in preteens?
So that's actually, so that's interesting. In a young kid and a 7-year-old, repeated self-injurious thoughts or statements is atypical. And so that would lead me to wonder, okay, what do we think is like actually, so what else is going on? So as I mentioned before, like this is the starting point of an investigation. So one thing that immediately comes to mind when a kid is repeatedly bringing it up again and again and again, I wonder, is there an anxiety disorder here? In particular, is there like OCD? Is there like an obsessional component to this thinking about self-harm or something like that? So I would sort of approach it with the idea being like, okay, what else is going on? Because this is not something that we would typically see in a kid this young. And so I wonder then, is this being driven by a depressive disorder? Is this being driven by an anxiety disorder? Is there some trauma history? What else is going on that might be driving that? And hopefully we could start to tease out what the sort of underlying driver of those thoughts may be.
So really using that as a way, because given all the information that you presented suggests that would be really unusual, using that as the beginning of that kind of learning and fact finding about.
Yeah, absolutely. It sort of means like, okay, we got to dive in and really try to get a sense of what's going on with this kid and why they're struggling.
Right. Dr. Sanchez writes, I just saw a 14-year-old girl this week with severe depression comorbidity. Thank God we had our own therapist in the practice. Oop, I just lost it. Oh, bear with me. We had our own therapist in the practice that I can refer ASAP for therapy, but mom refused to get any help. That medication is very helpful combined with therapy. Any suggestions how I can convince mom for additional drug therapy?
So I always start with so I think that's a really common, that's really common and I really glad that there is a good therapist that you may be able to get this kid connected to. I always start with, what's the concern? Because I think a lot of parents have totally legitimate concerns about, in particular, antidepressants in kids. I think one, if you read the New York Times and the reporting that's there, one question they may say is like, I worry a little bit that like the incidence of suicidality when taking an antidepressant has been underreported. And I'm a little bit worried that I'm not so sure these work compared with placebo. And I always would just say, those are totally valid concerns. And I think it's helpful for us to get a sense of, well, what exactly does the data say about suicidality and SSRIs? And the reality is that there is a black box warning. It's there for good reason. And it's possible that, in some of the more recent meta-analyses that maybe it's the risk is there, but it's not quite as big as the black box warning would suggest. And then sort of similarly, like in looking at the sort of response compared with placebo, like, yeah, actually there is a really big placebo response that exists for kids with depression and antidepressants. But we also feel pretty confident in adolescents that the medication is more effective than placebo. But, what are the concerns exactly? Is the concerns related to addiction? Is the concerns related to being on a medication lifelong? And just kind of getting a sense of where the reluctance is coming from, and then trying to address it in an honest way, because I think most parents have every reason to be concerned and in some cases skeptical about having their kids start a psychiatric medication. But I appreciate the difficulty in a short period of time of trying to make that case. So another thing I would just say is like, I can always hear no for an answer, but I always want to see them again soon, because it's all about building that relationship and getting enough trust with the families that I work with, such that, I may say, okay, there may be a time where I'm going to like stamp my feet and push a lot harder. And, having a relationship that can withstand that pushing, I think is really important. So sort of live to treat another day, I think is really useful.
Yeah, I think that's a really good way to think about it, of like, don't fight it at that initial conversation, but make it so that you can continue that conversation.
Yeah.
Patricia says, if the bill in the legislature reducing the minor age of consent for mental health treatment from 16 to 12 years old, how will this possibly change or influence how you treat the patient and their parents, i.e. if the patient requests that you not tell their parent?
So I'll be honest, that's a really interesting question. I had no idea about the bill and have not thought even for 1 second about that. So I don't know. Now I'm gonna see if I can scroll up and just like read it again, unless it's in the Q&A. But I'll be honest, I am not totally sure about it.
Yeah, so it's in the Q&A. It says the bill in the legislature, I guess, passes, reduces the minor age of consent for mental health treatment from 16 to 12. How would that change your treatment of the patient and their parents, knowing that the patient would then have more rights?
Yeah, that's a really good question. And to be honest, I'm not totally sure that it would change it that much. I think I would probably, give the same sort of like confidentiality spiel that I give. And there are a handful of psychiatrists that I think are able to delineate confidentiality a little bit more clearly. I like having that gray area. So I'd say, okay, now we got to talk about this because I'm not totally sure what to do. They'll say, confidentiality refers to what's going on internally, and but behavior is not subject to the same level of being able to keep that from a parent. So if you're planning on engaging in something or thinking about engaging in a behavior as opposed to just feeling a certain way, that's something that I'm going to have to tell your parents about. But as far as how would that law change things? I don't really know. And I say this to somebody who, for instance, just because legally I could start a medication on a 16-year-old without telling their parents, I sort of also will tell those same kids, like, yeah, legally we could do this, but your parents are probably going to find out at some point. So the idea of doing this behind their back, that doesn't seem like a very good idea. So let's figure out a way that we can all get everybody on the same page here.
Yeah, I think that makes a lot of sense. When possible, we want everybody to be in the loop. Anne writes, if the purpose of the self-harm is to decrease undesired feelings, how does the experience of cutting do this? By distraction, replacing with physical pain, gaining control?
So that's a really good question. And so one of the reasons why naltrexone is often used, or was used for a while, more broadly, I think, to treat kids with self-harm is because there was this thought there's some sort of endogenous opioid release and using naltrexone, we might be able to block that. So in some ways, maybe the self-injury will be a little bit less reinforcing, but it turned out, didn't seem to really work. And I guess I would say, the same thing about why antidepressants work. And the reality is, like, I don't know. The only thing I know is, when you talk to kids about, I could pretend to know and, point to brain pictures and stuff like that. But I think we're a ways away from understanding the mechanism of it. But I will say, a lot of kids will say they just feel like things slow down a little bit. That, I keep using the word temperature because that's a word that many kids have told me, it just feels like the temperature inside of me goes down. And in particular, that feeling of emptiness and that feeling of numbness, I can't sort of reiterate enough. It's a really aversive feeling that a lot of kids feel. And there's something about engaging in self-harm where, they go from feeling kind of empty and numb to feeling something. The self-harm doesn't necessarily hurt, but they can feel it. And that's something that they find really grounding in some way. Again, this is kind of speculation based on things that kids have told me. And I also think, it's kind of, there are 4 different ways that we can think about self-harm and what's reinforcing about it. So I think, what it does for one kid isn't the same as what it'll do from somebody else. But I think it's a really good question. There are lots of really interesting theories about it, but ultimately that's kind of all they are as of now. They're just theories.
Mm-hmm. Yeah, no, I think that's a good point. And I think that remembering that it can look differently depending on the child, and that's why you really want to kind of explore that with them. Last question just from me in thinking about, so what would be feasible if we were, if we have had the conversation with the kid in primary care, we have referred them to therapy, but they're sitting on a wait list. Is there something simple as a tool that we could give to the family to say, here's a skill I'd like you to try, that we don't need the context of, we know that DBT or CBT is on the way?
Yep. So that's a really good question. So, the first thing, I think the safety plan is important. A lot of kids may actually have already some skills that are in mind, and what they just are going to need is a reminder to use it instead of self-harm. And if they know that everybody, they know that now sort of the cat's out of the bag a little bit, they may feel a little bit more motivated to utilize that. So I think starting with the kid makes a lot of sense. However, I guess, if we're looking for other stuff, I mentioned DBT has a couple of different modules, and a lot of people think that sort of the starter module is what's called the distress tolerance module. So TIPS is part of that. There are a number of distraction skills or self-soothe skills. And again, these are really, how do you make a bad situation not get worse? And so I think those are in some ways the simplest skills to use and the skills that are most likely to get you through the moment. And they're often what people start using first. So I think you can refer families to, there are a number of different DBT skills workbooks. I mentioned Helping Teens Who Cut talks about distress tolerance. There are billions of DBT websites that have descriptions of the skills. So I think starting with the distress tolerance skills makes sense. My personal favorite, just to put a plug in, is the emotion regulation skills, in particular, opposite action to current emotion. But that's like a complicated, weird one that's a little counterintuitive, but it's awesome. It works really, really well. I highly encourage everyone to look it up and practice it because we should be using it all the time in our day-to-day lives. But yeah, starting with distress tolerance, I think, is the way to go.
Wonderful. Well, we are at our time. I want to say thank you so much, Dr. Kronsberg. This has been incredibly helpful. And thank you to all of our participants and your questions. We really appreciate it. Remember to take the survey that you'll get when you kind of close out of our event today, and to visit our website where we'll have a recording and a copy of the slides. Again, thank you for joining us, and we look forward to seeing you all again soon. Thank you, Cal.
Thank you so much for having me.
Bye, everybody.